we've seen like many women that didn't know how to contract their pelvic floor. So now we have evidence that which intervention could most help them.
You're listening to the Active Mom Podcast with host Dr. Carrie Pagliano. I'm a mom, physical therapist, and your go-to guide for staying active with pelvic health issues in pregnancy, postpartum, perimenopause, and beyond. Whether you're a fellow mom, physical therapist, or women's health professional, join me where I'll share expert insights, real-life stories, and the latest research to help you approach running, CrossFit, yoga, Pilates, HIIT, or whatever activity you love with confidence and evidence-informed guidance. Let's start the show. All right, welcome back to the Active Mom Podcast. It's research time again, and we've reached out to the MFM lab in Ottawa again and have a new researcher for the show, Dr. Flávia Ignácio Antônio. She is going to talk about a lot of different things from relaxin to pelvic floor, and we're just going to go right through her career so far because she's done a lot of work and there's a lot to chat about. So Flávia, thank you for joining us on the show.
Thank you very much, Carrie. Thank you for having me here. It's an honor and a pleasure to be here with you and to talk about what I'm very interested of, like researching women's health and pelvic health.
So where did you start? What made you decide to pursue pelvic health topics for research?
Well, so I'm originally from Brazil, and a long time ago, during my undergrad studies in physiotherapy, in Brazil we do internship in women's health. So in that time, like 20 years ago, I was seeing patients with problems, pelvic health problems, and we're already doing pelvic muscle training and behavioral therapy changes, and I saw a very important gap that I could address and help to investigate new researchers in this realm. Yeah.
Great. So tell us a little bit about, we're going to just kind of go through some of the studies that you've done and some of the topics. What was one of the first areas that you started to research?
So I started looking for understanding better the hormones. So my master and my PhD was about, for example, my master was about polycystic ovary syndrome, PCOS. So we want to investigate the function of pelvic muscle and the signs and symptoms of urinary incontinence in this population. So we compared both PCOS versus control, and we did not find differences in function, but we saw differences in signs and symptoms. So women with PCOS did not show urinary incontinence, whereas controls had. So we started looking at function, like manometry, electromyography of the pelvic floor muscles in this population. And then we jumped into post-menopausal women that were taking hormonal therapy and those that were not taking hormonal therapy. And we were investigating, yes, this one. And we were investigating the effect of pelvic muscle training in both groups. And then we saw that women that were not using hormonal therapy had better pelvic floor muscle function than those not using hormonal therapy, right? And then later on, we saw that systemic hormonal therapy could negatively affect the urinary incontinence because the target of these hormones are not only muscle, but also into the central part, the micturition center, the pontine center micturition that controls the urinary tract. So relaxing, for example, the urethral sphincter. But the goal of our study was to see the effect of pelvic muscle training, and this training improved better women not using hormones.
Okay. And this is in postmenopausal women. And looking back at the date, 2018, it's been more recent here, at least in the United States, that hormone replacement therapy, I think, is more widely accepted. I'm assuming a lot of these women were on hormone therapy before they became postmenopausal, or do you remember?
So the differences can be topical and systemic, right? The one that we saw, that we investigate, was a systemic, and that's
Systemic.
why could like influence in a different view that we were aiming for, right? Like we were hypothesizing that this could help improve muscle function, but again, muscle function sometimes doesn't has to do directly with helping urinary incontinence.
Right.
Maybe it's an indirect help, you know?
Right. So it helped the muscles, but maybe not so much the micturition center.
Yes. Yes.
Okay. If you had to do a jump off study from this one, knowing what you know now, where would you go next, do you think?
So hormones is really hard to investigate. You mean hormones, right? Because, for example, the article that talks about relaxin, diabetes in during pregnancy. So we found out that a woman that has urinary incontinence during pregnancy and that has diabetes had lower relaxin in the blood, so bioavailable. But what does that mean, right? Because we don't know if this is because it was less produced in this population, or if this relaxin was more bounded to the tissues, to the muscle, right? So this would be a path to investigate, like to check the muscles, right? The rectal abdominal muscle, but this is really hard to investigate in pregnant women, or during delivery, maybe in C-section. We could do a biopsy in the rectal muscle to see the levels of relaxin, and if that would be associated with more urinary incontinence or not.
Can we take a step back for a second? Before we started to record, I was mentioning to you that there's not a lot of papers about relaxin, but relaxin is something that, at least here in the United States, a lot of women are told is the source of many of their problems in pregnancy and postpartum. Can you tell us what relaxin is, and generally when should we expect it to elevate, and when we should expect it to drop, and kind of what's the purpose of relaxin? What's its role?
So it depends on the stage of the week that the pregnancy is it increases, and it stops or near the birth, because the body is preparing to give birth. So if we are going to measure it, I think we should measure, like, determine the stages of the weeks that the woman is pregnant, but it's we really don't know, actually, like, if it helps, if it doesn't help. It's like there's a lot of gap in this area still, because I think it's hard to measure.
Yeah, I think there's a lot of things hard to measure. I mean, the pelvic floor obviously is hard to measure too, but I've heard, and maybe this is incorrect, that relaxin will increase the first trimester, so maybe the first 12 to 14 weeks, and then sort of level off at that point. But a lot of the changes that women experience with kind of loosening of ligaments and things like that is actually more of a role of estrogen. Is that somewhat accurate?
Yeah. I think that is in line with the literature. Yeah.
Mm-hmm. And then sometimes also, I just heard this recently that I had a person reach out, and she said that her therapist told her she was breastfeeding in postpartum and that the relaxin would stay high until she stopped breastfeeding. And that didn't sound right to me. What do we know about after delivery? Or do we know when that drops? Because what you're saying is basically we would need to biopsy muscles to see what the level is. I don't think any mom's going to volunteer for that.
Yeah, in terms of muscle, if you want to see how a hormone is playing a role in the tissues,
Mm-hmm.
I think the biopsy would be the thing,
Mm-hmm.
because so like the available relaxin in the blood, I don't know if we can say for sure that
Yeah.
this is playing a role,
Mm-hmm.
right? Or what if the body is not producing enough? That's why it's showing lower level of relaxin in the blood, you know? So there is a lot to investigate there. We cannot say that high levels of relaxin could, right? And
Yeah.
also we know that, for example, if we are talking about urinary incontinence, it's a very complex condition.
Right.
It's not only one thing.
Right. Yeah. I think we like to simplify things. And relaxin sounds so simple. It's relaxin. Everything is relaxing. And I think the public is oversimplified. And because there's not a lot of information about it and how to get levels and things like that, it makes it very easy to misinterpret. This study that you did in pregnancy, how did you collect the information about relaxin?
So it's a big study that I contribute. It was actually a study from a group, the amateur group, in the state of São Paulo, Brazil. And they collected during blood, like in blood sample, right? And during the semesters, depending, the weeks of the pregnancy. So that's what they did. I don't know to tell you the details, how the sample were analyzed and all of that, but was blood samples.
Okay. Yeah. And with that, what you were looking at was the impact on continence and function with that study?
Urinary incontinence.
Okay.
Yeah.
And what would
the presence of urinary incontinence in which group, right? So we had, and also associated with diabetes during pregnancy. So we found that women that has diabetes and urinary incontinence had lower levels of relaxin in their blood.
That's interesting.
To the ones that did not have diabetes, for example. And we know that this condition could help pelvic muscle disorders in not only pelvic floor, but also other muscle disorders. Maybe diabetes could be playing a role in that too.
So that's interesting. That's something that we don't tend to think a lot about. I think as physios are some of these other systemic things that can go on during pregnancy and any relationship between the two. So that would be interesting to know more about.
Yeah.
Where did your research go next?
So then we did, so I think we would like also to talk about acquisition of pelvic muscle contraction on those population that doesn't know how to contract the pelvic muscle, because this is a prerequisite to do pelvic muscle training, right? And we know that more than 30% of women doesn't know how to contract the pelvic floor muscles. So we did systematic reviews to see if there is any interventions helping women to contract or to acquire the capability to contract their pelvic floor muscles. And we didn't found any RCTs that investigate that. So we did 2 RCTs to investigate which intervention would help women that had 0 or 1 in a modified Oxford scale, so no contraction or a flick contraction, to see which intervention would help them to acquire this intervention. So we tested pelvic tilt, posterior pelvic tilt, laying down with palpation feedback alone, and electrostimulation, comparing to control. And we saw that pelvic tilt, posterior pelvic tilt with palpation as a feedback would help them to acquire this ability to contract their pelvic floor muscles. So it's very important us to know, because sometimes we think that just the educational part, like explaining them, it's important. I'm not saying that it's not important. It's important to explain anatomy, how pelvic floor muscle function, the contraction, but just by explaining, it doesn't mean that they will learn how to contract up, like especially those that doesn't know how to contract, right? So I often think about, for example, women that goes in classes like a yoga class, Pilates class, and they engage them to contract their pelvic floor there. But how do they know that they are doing correct?
Right.
So this is very important because it seems rare, but it's not. Here at University of Ottawa in Brazil, I've seen many women that doesn't know how. And this research question came from a clinical setting, right? We've seen like many women that didn't know how to contract their pelvic floor. So now we have evidence that which intervention could most help them. So pelvic tilt, posterior pelvic tilt with feedback, palpation feedback, but also electrostimulation with attempt to contract the pelvic floor muscles. So these 2 were like the main ones, but we have other ones that if they don't acquire using those, we can use other strategies as well.
Did you, I know one of the first things I was thinking of when reading this was, I think, and years ago, that was one of the primary reasons that physicians referred patients to us, was because, you know, we were the pelvic floor muscle contraction people. We were the Kegel people. And that was our first role, was to teach people how to do this. Now looking back at that, I think of almost 2 possibilities of patients in my head that wouldn't necessarily know how to do a contraction. Somebody that really, you know, they have the capacity to do it and maybe just needed that motor retraining or something along those lines. Or somebody maybe that is higher tone, and when if you did not realize that, which, you know, if you've been doing this for 20 years, you know, too, we weren't recognizing high tone as well, you know, 20 years ago. Somebody that may already have a lot of tone and they seem like they can't contract because they're in that higher tone. Do you remember back if you controlled for those people that may have had more high tone versus regular tone?
So we included only women that would not be able to contract their pelvic floor muscles, but I think we didn't include anyone that had higher tone, because I understand what you're saying, like they are already contract and it's hard to relax and hard to contract. I know we exclude those patients.
I would like to know that study on them too.
Yeah, that would be great. Yeah, so many things waiting to be discovered. I like that. Like, no, we have many things to discover that's there, that we need to find out.
I think that too. I think that's the one thing that I really appreciate is that the answer to all of this exists. It exists. There's a reason for everything. We're just not privy to that yet. we don't know what that is yet. So we have to keep working to find those answers. So I like that you say that. And well, as a researcher, that's important. So let's keep moving. What was your next area?
So we also here. So then I came after my master's, PhD, and the postdoc that I did in Brazil, which was this investigation of acquisition of pelvic muscle contraction. I came to Ottawa to study with Linda McLean, which is an amazing researcher. And while we were collecting data on my postdoc here, which was around what's the nature of pelvic muscle in PVD, provoked vestibulodynia. While doing the data collection, we did a secondary analysis to understand does stress urinary incontinence result from pelvic muscle weakness. And I think we were already talked about this a little bit, and I've been seeing podcasts. I think Marina mentioned that as well. So we didn't see associations in improvement in pelvic muscle function. So everything improved. So we analyzed the ultrasound morphology, but also pelvic muscle function, and everything improved after pelvic muscle training. But there was weak association between them, like improvement in signs and symptoms of urinary incontinence and, for example, strength, right? So we need to look. So what is the results, the conclusion on that? We need to look beyond the strength, right? Maybe it's something about motor control, right? That we need to investigate, and also see if including that more specific in our pelvic muscle training would help better. Like women that does not benefit from pelvic muscle training, or because not everyone decrease their symptoms after pelvic muscle training. What about the outliers? Right? What about the outliers? So we need to investigate that. And then with the same sample that we did, we investigate about the neck maneuver.
Can you explain what that is for somebody who may not know?
So the neck maneuver, it's a pre-contraction of the pelvic floor previous to an increase in intra-abdominal pressure, for example, coughing, laughing, sneezing. So I also do a parallel, like we bring our arm when we cough, right? So we need to bring our pelvic muscles before these tasks to prevent a stress urinary incontinence, for example, right? So we investigated the ability of women to acquire this maneuver automatically after being told. Like we just taught them how to contract, to do the neck, and they did the pelvic muscle training. Then they came back to analyze if they were doing or not by ultrasound. So we did that using ultrasound. And what we saw was that 1 in 4 women would be able to acquire this maneuver automatically when we asked them to cough. So it was in a research setting, was not in a daily life activities, right? But this was not, this improvement, the ability to do the neck was not associated also with the improvement in their signs and symptoms of urinary incontinence, right? So maybe we need more researchers to check. The limitation of this study also was that we did not incorporate the neck during their pelvic muscle training. We just told them how to do in the baseline and asked them to do again in the follow-up. So maybe if we incorporate the neck, would that be more effective comparing just a pelvic muscle training standard one?
Yeah.
We don't know. We have a study being done in Brazil that they already published their protocol, but I don't think the results are out just yet. So I'm looking forward to know if, and then they are gonna do a group only with the neck, the association of the neck and pelvic muscle training. I think there is a control as well. So it's important to know like the effect and the benefit of including it.
Right. It's so interesting. Two things I was just thinking about as you were talking. One, to go back a little bit, was to strength in the pelvic floor is, I think, the foundation that so many of us are taught with, even new physios today. And I think those of us that have been doing this for a while know that it's more than strength. And that's why I'm so glad that papers like these are coming out, because when we used to only do strength, we would get some people better, but not everybody. And that never made sense. You could have somebody that was very strong and still have symptoms. You could have somebody that was quite weak and you could get their symptoms improved. But it's interesting, that's the one thing that continues to prevail when you look at Facebook groups with, moms or, people that are trying to address their pelvic problem, is everybody's still talking about strength, even though there's so many of us that for years were like, there's something more, there's a coordination piece, there's something else. Why do you think we're still holding on to strength so much?
Maybe we need to do more knowledge translation. I think what you're doing here, it's great, right? I think we need to be more active in social medias and like spread the word, I think.
Yeah.
I think that's what it's I don't know. What do you think?
Yeah, it's something I ask myself every day. No, it's so interesting that you would, I mean, I do understand the concept that, once research comes out, it can take up to 20 years to get into practice. Having done this for 25, I'm glad it doesn't take that long for some of us. But I think it goes back to simplicity. I think this area is so exquisitely complex and amazing, and the average person, I think, we want the simple answer, and strength is an easy concept that we're taught about as kids, to be strong, and if you have strong muscles, you have healthy muscles. And I think it's a hard thing for us to explain, and we're still learning the intricacies. And I think until we're more clear, I think then we'll find a way to kind of explain that. But what I try and tell people is, being continent is far more than just your pelvic floor strength, because let's say that was it. If you were weak, then all of a sudden that's it. Like that's not a very redundant system. That's not a very efficient system. And so I have to believe that as we were designed to have backup systems and multi things working, in case we lose strength, and then we've got something else that, keeps us going. But yeah, I think we've gone much further, I think, even in just the last 10 years of my career than the first 15, as far as understanding things. And I think that's one of the big focuses of your lab, is figuring out what we're measuring and how to measure it. And it's such a weird place to figure out how to measure. So, I mean, that must be hard as a researcher to try and figure out what are you actually trying to measure and what can you do to harness or to gather that data.
Yeah, to test, especially motor control, like motor control theories, like haven't been applied to treating pelvic muscle disorders yet. So, but they could be really relevant for improving treatment. So, but it would be challenging as well to evaluate, for example, regular performance of the neck maneuver in a community setting. For example, if it may be beneficial to incorporate, like we did only during coughing, but would be important to incorporate it during laughing, sneezing, other types of tasks. But again, it's hard to measure.
It is, but I think the Knack, and I think this is another hard thing too. I mean, the Knack was one of the very first things that I learned to manage symptoms. And for some people, it works. And then for others, it doesn't. And I think where I forget sometimes that some of these basics, we want to just check the box and make sure, like, go ahead, try this, make sure if it works, great. If it doesn't, that's fine too. But I think sometimes as we're getting excited of the complexities, we do forget the basics. And sometimes we just have to go back and check the box because sometimes that might be that simple. But this year, I don't know how it's been in Canada, but this year I had lots of patients with flu A, flu B, RSV, norovirus. So everybody was coughing and vomiting all winter, like all winter. And so I don't think the Knack worked for that long, for that much coughing, and the Knack for vomiting, that's an interesting one too. So whenever you get to the study where you're studying somebody doing it over a 4-month period of time with 5 different respiratory viruses and vomiting, I have plenty of patience for you.
Yeah, it's a complex system, right? Only the Knack or maybe pelvic muscle training won't solve the problem. And of course, these are like specific periods of life, right? When coughing.
Right.
So not everyone has a system that's all in place to hold that together, right? So we need to take it into consideration.
Yes. And I think there's so much more we're learning about birth injuries and the impact of them and so on and so forth. So yes, there's a lot of different buckets. Where did you go from there? What's the next bit of research?
So then now I'm getting the results from my postdoc, which we wanted to understand the brain-body connection in chronic pelvic pain and test interventions. So as I was saying, I wanted to understand what is the nature of pelvic muscle involvement in provoked vestibulodynia. And we did a huge study. Not all the results are out there yet, but we tested the EMG, electromyography activation of the pelvic floor muscles during tasks like rest or pelvic floor muscle contraction and Valsalva maneuver, strain maneuver, to see if the activation were greater in women with provoked vestibulodynia comparing to controls. And we saw that, yes, provoked vestibulodynia group had more activation in the superficial layers. We did a very comprehensive assessment using electromyography, specific electrodes to target the deep layer, the pubovisceralis muscle, and also the superficial layer, the external anosphincter, and the bulbocavernoso muscles. And we saw that during these tasks, women with PVD had higher activation of their muscles, especially the superficial layer, comparing to controls.
And just to
So,
clarify, provoked vestibulodynia, basically it's a type of vestibulodynia where if you touch, it's uncomfortable and painful versus unprovoked.
yes, it's defined as sharp and burning pain experienced at the vulvar vestibule, the vaginal entrance, upon touch or pressure. It means sexual or non-sexual activities. So it's very prevalent. 1 in 7 premenopausal women have this condition, and it's a challenge. It's a challenge processing for them to disclose that with the healthcare providers. So it was very interesting to study these women, and I feel very lucky to help somehow them to, and for us to find better approach to target these muscle activation. So for example, in this study, we saw this greater activation, and this will help us to target not only tone, but also the overactivity, which is not only tone, it appears to be a broader neuromuscular characteristic of provoked vestibulodynia. So it doesn't seem, we did some correlations about pain sensitivity, and this overactivation doesn't seem to be related to pain during these activities. But so this study supports physiotherapy techniques that focus on relaxation and control of the pelvic floor muscle. But this cannot be a solely approach, right? And we already know that for this population, we need to apply multimodal physiotherapy. But when we did a study, which is the other one that is the same sample size, but to check how these muscles respond to pressure, so apply to the vulvar vestibule, but also to the posterior thigh, to check the remote responses to pressure to remote sides. We saw that comparing provoked vestibulodynia to control, we saw more activation in the pubovisceralis muscle, so the deep layer, and the external anal sphincter. So, but the external anal sphincter muscle responded higher in both groups, controls and PVD. So, yeah. So we have some thoughts on that. Because of the pressure, it could be give to the muscle like the stretch response to the spindle muscle response for like activation, and or withdrawal response as well. So everyone did respond, but the pubovisceralis muscle responded higher in women with PVD. So the take message on that is when we are assessing and checking the improvement after our intervention, maybe we should not only look at the external anal sphincter because it will be contracting upon touch, upon pressure. So we need to think deep, like to assess deeper, like the deep muscle layer in this population.
This group that you looked at, was this a particular age group? What was the average age?
The average age was around 30 years old. So premenopausal women. Yeah.
Okay. Yeah. No, it's interesting that you have kind of shifted over to look at pelvic pain diagnoses, because I spent a long time working with that earlier in my career and understanding, the higher tone muscles and whatnot. And that's what made me start to think differently about high tone for stress urinary incontinence, and even what we think. And I've talked to Linda a little bit about this, that like I don't know if our hypothesis is right, but at least the treatment seemed to be working. And she's like, that's okay, keep doing what you're doing and we'll figure out the why later.
Yes.
But just thinking about people that have pelvic organ prolapse, and maybe they don't have much anatomical prolapse, but they do have that heightened awareness or that heightened sensitivity. And we're finding that they have those signs of a higher tone or higher muscle activity or something along those lines. But when I, probably similar to you, when I was first, becoming a physio, it was, if it was incontinence or prolapse, it was always low tone, always focus on strength. It was only pelvic pain that you could focus on higher tone. So I think it's interesting that you're kind of crossing back and forth with some of the things that you're studying too. Has that been something that has been a conscious progression for you, or how are you figuring out sort of what things that you're interested in next as a researcher?
Yeah, chronic pelvic pain is very interesting to me. And we are still in this line. So we also did a photobiomodulation intervention, RCT, to test the effectiveness to reducing pain. And right now we are doing another RCT, actually two, because this one of photobiomodulation was a pilot study. And now we are doing a more, a huge sample size. We are aiming for a greater sample size. And also we are doing an RCT for endometriosis-associated pain using repetitive transcranial magnetic stimulation. So I think we have lots of things to study in regards to chronic pain in general, especially because now we are looking more into the psychosocial factors that could play a role, right? Not only physical pain.
Right. I don't know if you saw the Canadian postpartum guidelines that Margie Davenport's group just put out, and talking much more about the psychosocial aspects of navigating pain in pregnancy as well. I think it's so unique that we've got these different areas of pelvic health, but we have these umbrellas that are connecting them in this area. Where do you see research going as far as that's concerned?
Well, I think we need to investigate more about how our interventions play a role in psychosocial outcomes, which is what we are doing, like central sensitization. Does our interventions could decrease that central sensitization, for example, and anxiety, fear, or like experience, because we know chronic pain is all about experience, individual experience. So I think we have so many to study in this area.
Yeah, I think so too. When you were back in Brazil practicing, and did you see any of these pelvic pain patients, and how did you treat them then, and then how might you do something differently now?
I think looking at those aspects, psychosocial aspects, like understanding better their feelings about their pain, how they understand pain, education is very important part of the treatment. I think we are more aware about this right now than in the past. I think in the past we were more like hands-on. We still need, but I think we also need to have these tools in terms of addressing psychosocial factors with them that could play a role in maintaining or perpetuating their pain, and how they understand pain, but also their body understand pain, how their body process the pain. And that's what we are trying to to intervene with or test the intervention with repetitive transcranial magnetic stimulation in women with endometriosis associated pain. So those that did surgery to remove lesions, but still have pain. Are the pain still there because of central sensitization? Are the lesions regrowing their pelvis? So yeah.
That's really interesting. Having treated endometriosis patients for my whole career, because for a long time, at least people are recognizing it now. It's very public. There's a lot of celebrities talking about their diagnoses. Whereas for a very, very long time, we would see these patients and we would be trying to help them get a diagnosis and find surgery. But still now I feel like I have a couple current patients looking forward towards surgery. It was very clear. I think we're doing much better getting earlier diagnosis, especially at an earlier age, but being able to predict their response to surgery or whatnot. I think we still have some work to do there. So that'll be really exciting information.
Yeah.
I was thinking back to what you said, central sensitization. Can you explain that just a little bit for the average person that might not know what that is? And then hearing you say it, they might understand a little bit more and maybe recognize something in themselves.
Yeah, so central sensitization means that how the body is understanding or processing pain, and this maybe is due to spinal pathways or central pathways, like the representation of the area that we are investigating. For example, the abdominal area represented in the brain. How does those connections are working with each other, right? So one way of measuring central sensitization that we are doing here is through temporal summation. So, and this could be tested in different ways. We do pressure testing repetitively. So with time, the perceived pain intensity is increased, right? And this means that the person could have central sensitization. So by testing with, for example, an algometer. So we are using an algometer in their abdomen to test if they do or do not have central sensitization. I don't know if that's clear. But
I don't know what an algometer is.
It's a pressure sensor that gives you the unit in grams or newtons, how much pressure you are applying in that area.
I see.
Yeah. So it's an interesting tool to test, like pressure pain threshold, pressure pain tolerance, perceived pain intensity, and also temporal summation.
Okay.
Of pain.
That makes sense.
Yeah.
That makes sense. The first time, my background is also in sports and orthopedics. And back when it wasn't all mashed up together, it was a very separate pathway. And I remember first learning about central sensitization from a couple of Australian physios, David Butler and Lorimer Moseley. And back in, I think it was 2013. No. Hang on. It was 2014 because my youngest was 6 months old. And we took her to Vegas for a conference. And it was on my oldest son's birthday. And the reason why we left him home and took my 6-month-old to Vegas was because a colleague, Sandy Hilton, and myself had the opportunity to present at a national conference with Lorimer Moseley about, he was going to talk about central sensitization in the context of low back pain and chronic regional pain syndrome. And we were going to talk about how we were adapting that thought or that concept to pelvic pain and dilator use for graded exposure and all sorts of things like that. And so I remember at the time that I was willing to do that because it was such a profound topic. And here we are, what is it, 2025, over 10 years later. And finally, we're starting to get some research into, we were just taking a concept that we thought made sense in the context of the patients that we were seeing. And it's really cool that maybe we were on the right track.
Yes, that's amazing that you had this opportunity.
Yeah.
And I could realize that in 10 years ago, right?
It's really neat. I think one of the best things about practicing in this area is that you do get to know, you get to study pain, you get to study, work with urologists, work with gynecologists, work with colorectal. Like we get to, talk to people who know a lot about a bunch of different things, and then take that and extrapolate it to see if we can understand more about this part of the body that nobody has seemed to want to pay attention to for a long time. So it's nice to be constantly learning something, although frustrating some days.
Yes. Yeah, I think we have to keep together and motivating the motivation between us, because this is very important. And treatment in women, we've been seeing like historically that needs improvement, right?
Yes.
So
yes.
So we need to remind ourselves about that and keep the motivation.
Yes, especially here in the States, we're relying upon the Canadians and everyone else to keep the research going. So for you, let's talk a little bit about you personally. How much time are you in Ottawa, and do you get back home to Brazil every once in a while?
Yeah, just to visit for now. I'm doing my research. I'm a clinical research associate at the university. I had the opportunity also to teach here at the physiotherapy master program during 2 consecutive years. And I also mentor students in the MFM lab. Mm-hmm. While leading some RCTs right now that I just told you, like the endometriosis and the PVD. Mm-hmm. And that's like very busy, like always very busy research. And in Brazil, I also collaborate with studies there from my formal lab there, the LAFAP, led by Christine Onsi. Mm-hmm. So I'm always like in contact with them, like participating in defenses committees, not only there, but here in Canada. I'm also associate editor in the Brazilian Journal of Physical Therapy. So I have to help them to deal with like peer review process and all of that. So it's really interesting because I get to know what's up there and what people are doing around the world.
That's great. And so looking ahead for you, are you going to continue focusing on a lot with pelvic pain, you think, since you've been looking into endometriosis and whatnot?
Yes, I think so. Also, I keep the interest in about educating women about pelvic health and pelvic floor muscles in general. So I'm always like looking for studying not only chronic pelvic pain, but also pelvic floor disorders, which includes not only urinary incontinence, but also pelvic organ prolapse. I'm very interested in pregnancy and disorders that can happen during this period of time of life. So yeah, I love research. So
that's great.
I will keep
going.
Yeah.
Well, if you ever do a crossover study comparing, pelvic pain and those patients, like I said, with prolapse, that they have the symptoms, but not necessarily an anatomical prolapse, I would be super interested in that. I think there's something there. I don't know what it is yet, but that's why if you guys want ideas, I'm sure all of us clinicians will just make a huge list for you.
Yes. I think we can set a time to talk more about that.
That sounds good. That sounds good. Well, thank you so much for being on. If you guys would like to know more about Flávia, you can find her here on Instagram, Flávia Ignácio Antônio, and then also their work at MFM_lab. Flávia, thank you so much for joining me, and we look forward to more of your research in the future.
Thank you so much, Carrie.
If you're navigating pregnancy, postpartum, or perimenopause, whether personally or professionally, check out all our free resources and upcoming courses at carriepagliano.com. This podcast reflects the opinions of Dr. Carrie Pagliano and her guests, and it is for entertainment purposes only and should not be considered medical advice. Always consult your healthcare provider with any medical questions. If you enjoyed the episode, please take a moment to leave us a 5-star review on your favorite podcast platform. And thanks for listening.